Today, we are piloting a new podcast format where we go through a case study so you can hear what occupational therapy sessions actually sound like and the clinical reasoning that is going on inside the brain of expert clinicians. I learned a ton from this episode, and I am excited to keep strengthening this format. If you have any ideas for me, please don't hesitate to share. I also wanted to let you know that you will hear us talk about a full clinical decision support page that OT Potential Club members can access inside the club. But even if you are not a member, you can find a public-facing version of this page by Googling OT Potential and our page on cancer rehab for young adults. Okay, let's dive in. Welcome to the OT Potential Podcast. Before we begin, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. After listening, you can log into the club to take a 5-question quiz, and we will generate a certificate for your time today. Okay, here we go.
Hello, everyone, and welcome to the OT Potential webinar cast. I'm Alan Linick. I am your host for today's webinar. Today, we'll be talking about cancer rehab for young adults. Our guests today joining us, first of all, Vanessa. Hi, Vanessa. How are you?
Hi, I'm excited to be here. Thank you for having me.
Oh, yay. I'm excited to have you as well. This is Vanessa Monique Yanez, PhD, MSOT, OTRL. She's an occupational therapist specializing in cancer rehabilitation. As a cancer survivor herself, she brings both professional expertise and personal insight to her work, shaping her approach to patient care and the development of meaningful evidence-based programs for those navigating life during and after cancer treatment. Very excited to have you, Vanessa. We are also joined by Sarah Lyon. OTRL is the CEO of OT Potential and is on a mission to bridge the gap between research and real occupational therapy practice. Hi, Sarah.
Hello. I'm really happy to be here. I have to say this is a full circle moment for me because working as a generalist, I just always wondered what specialty clinicians were doing. And I especially remember seeing cancer patients and feeling like I wanted to know more. I wanted to know what people like Vanessa were doing. So I'm so excited to try this case-based approach to this webinar today and just hear how Vanessa goes through a session.
Yeah, we're going to kind of set up a scenario with a fictitious patient that we've created some details for to go through a specific case, kind of walk through it that way. But first, Vanessa, would you care to share a little bit about your own story just to contextualize what we're going to be talking about today?
Yes, of course. So I've been an OT in cancer rehab pretty much my entire career. I've been doing this for over 10 years, 11 years or so. And I ended up in cancer rehab after my own personal experience with cancer. I was an AYA, an adolescent and young adult cancer survivor myself. And I remember that going through treatment was very difficult, but life after treatment was a lot harder. I did not expect that at all. And I think at the time, I felt that everybody just saw me as young and strong and abled. And I think the assumption was, she's going to figure it out. She's young, she's good, she's able to walk and recover. And that's something that I see and I hear often nowadays with AYAs too, where they're saying, yes, I'm young, but I'm still dealing with all of these issues and I don't know how to move on. I don't know how to go back to my previous life, or how do I move on from here? And so through my personal experience, I've learned that this area still needs a lot of attention. We still need a lot of work and research with AYAs. A lot of the research now and even clinical practice is really focused on pediatrics and older adults. There's very much a dichotomy in care right now, but AYAs have their own very unique needs. They're going through major life transitions. So think back to when you were in your 20s and your 30s, you're still trying to figure yourself out, who you are, what you want to be, if you're going to go to school, who you're going to date, whether you're going to have children or not. And so cancer can disrupt all of those things and your development, meaning those developmental stages and being able to form a positive identity. And so a lot of my work has been in AYAs in the survivorship phase. And that's where I focus on my dissertation as well for my PhD.
Yeah, statistically, I feel like it's almost impossible not to have cancer touch your life in some way or another, whether it's dealing with it yourself or a family member or a friend. And I guess I always really thought in similar terms of like, yeah, or if you're in remission or you've beaten whatever your diagnosis is, all done. Like, hooray! Like that's time to celebrate and like move on and quote unquote return to normal. But the idea that there's still potentially so much to do and that there's like a chunk of the population of cancer survivors and patients who are sort of expected to find their own ways.
Yeah, and there's so much we can do as therapists, and something I'm just so thankful to Vanessa for is she helped us at OT Potential create a clinical decision support page that really walks through like the possible assessments you can use. There's a goal bank for you, there's treatment options, and you can just really see all the things that OTs can bring to treating this population. We know that just not enough people get to cancer rehab, and we want more to get there, and we want more OTs to feel equipped in this. So that's definitely part of our mission here today. So, and that clinical decision support, it will be linked for you in the comments as we're talking today, so you can kind of peruse through the different options that we'll be talking about at each stage.
I think I'm gonna set the scene a little bit for our fictitious patient that we're going to be talking about and using to sort of define and describe our approach. So we've created a profile for a woman named Samantha Tan, who is a 38-year-old female with stage 2 breast cancer, ER positive, PR positive, right breast mastectomy around 12 weeks ago, and currently on, I'm going to attempt to pronounce this medication, letrozole.
You got it.
Ha, nailed it. Okay, great. Which is an aromatase inhibitor or aromatase inhibitor. So the reason for her referral is that her breast surgeon referred her to OT due to right UE pain, some range of motion limitations, fatigue, and vaginal dryness. And for our setting, we're gonna establish this just as part of an outpatient OT evaluation. She walks in the door, she's on time, her husband is with her. I mean, I presume, at this point, she's gone through so much treatment of various kinds and talked to so many different specialists already. And, she's undergone this mastectomy procedure as well. And I imagine at this point in time, she's like close to burnt out. I can easily see, I'm sure you deal with a range of personalities and people in various stages of how motivated or how optimistic their outlook is. But I have to imagine for this situation that this is someone who's like, great, another thing to do on my road to recovery, right? So I guess we'll start with Sarah. What's your first initial feeling as you walk into this situation from your side of the treatment scenario?
Yeah, before I even walk into the room, I want to talk a little bit about the chart review and thinking, first of all, I get this referral working as a generalist. Honestly, I'm a little intimidated because I'm used to seeing older adults, just stands out on my caseload probably. And doing that initial chart review when you get those cancer patients that it feels extra intimidating because honestly, there's so many more words that are not in my normal lexicon. Unfortunately, lots of our other diagnoses are like bucketed, like depression is like this huge bucket with all of these different variations. And in cancer, they're actually way more advanced. And so there's way more granular information about the diagnoses. There's way more medications, which is awesome, but makes it hard for generalists to do that initial chart review. So I guess I want to punt to Vanessa and be like, as you are looking at that chart, like what are you looking for before you go into the room to kind of prep your mind for what would stand out there?
Yeah, very good question. And before I see the patient, I already know who the patient is, their name. So I have some of the basic like demographic information. And I think it also varies where you're working too. I think if you are in a large facility or in a large hospital, you have access to a lot of information through the EMR. But if you're out in the community, a solo practice, or a small location, you might have received a referral from a local provider, and there might be just minimal information in there too. So I'm going by some of my experiences working at a hospital where I'm able to access, let's say through Epic, which is a large EMR. I'm able to go in and look at the notes, and I want to have an idea of what the patient might say and how they might look coming into my session before I even see them for the first time. So in terms of demographics, I know she's AYA, she's a 38-year-old, and AYAs refer to individuals between the ages of 15 all the way to 39 years of age. So this person, 38, will be considered an AYA. She's female. Her pronouns, she and her. Her primary language is English. Her main cancer diagnosis is breast cancer, stage 2. And I already have an idea, okay, she's gone through some treatment, she's had the surgery, she might be on some medication. What kind of medication is she? So that's what I'm wondering. I want to look into her medication list as well. I also noticed that prior medical history, there really isn't none. So she was relatively healthy most of her life. So I'm also guessing that she's going to be really overwhelmed as well, like you said, Ellen, with this diagnosis and the treatment. And I see this so often too with women that when they come to me for the first time after going through treatment, they're really just starting to process what just happened to them. So everything might have gone through so quickly from the moment they were diagnosed, going through chemo, surgery, and they were just in survival mode, go, go, go. And so after they've gone through treatment, after they've gone through their surgery, that's where some of them have some time to just stop and reflect and like, what just happened to me? Like my body is completely different. I don't know if I'll be able to go back to work. How am I going to care for my 7-year-old? What is next in my life? So those are some major life and existential questions that people have all the time. So I do anticipate this person being overwhelmed with everything, especially because I haven't seen any rehab services in their chart. So I'm also trying to figure out, did this person receive any rehab, any OT, any PT before their surgery, ideally, or even after their surgery? So through this person, I didn't see any rehab, no prior medical history. So breast cancer is their only diagnosis. And they're also on letrozole. So this medication, because I know that the type of breast cancer they had is fueled by certain hormones. And in her case, it's fueled by estrogen and progesterone. So then that means that there's some medications that can block the effect of those hormones fueling cancer, the breast cancer. And so some hormone blockers like letrozole, anastrozole, those are hormone blockers, which is a good thing, but also they come with side effects. And so very frequently I see joint pain, symptoms of like perimenopause, mood changes, vaginal dryness. And so I'm also anticipating fatigue, a lot of these potential side effects that I want to screen for. Other things that I'm wondering is what kind of surgery. So right side, right breast, vasectomy. And the reason for referrals, typically it's very much physical issues when I see a referral order. It might be pain, might be limited active range of motion, but I already know off the bat there's going to be a lot more than that. There's likely going to be fatigue, just like me, there might be some chemo brain as well. There might be some joint issues. So right off the bat, I already know she might be dealing with multiple things that I want to screen for. I go back to the surgeon's notes in the EMR. Everything went pretty smooth in terms of her surgery, no complications, no infections. And the only thing in terms of her labs is that she's a little low on vitamin D, which happens from time to time. I think a lot of us, even those without cancer, might be a little deficient in vitamin D, so that's expected, but might be also contributing to her fatigue levels too.
So out of curiosity, with a patient like this who's been referred by a surgeon for issues that have occurred as a result of medication or directly as a result of like a procedure like a mastectomy, what expectations does a patient usually have coming into an OT and looking for help? Like, because I imagine there's a decent number of people who walk in and they're like, I was referred. I don't even know what OT is. I just am really looking to get range of motion in my right side back, or people who are like, I'm here. I expect, because I was referred for these issues, I expect 100% recovery in these areas. What can you talk us through typically what a patient in this kind of scenario, what their expectations of you would be, or how you go about setting or adjusting expectations for a patient like Samantha?
Can I add to that almost like a role play, Vanessa?
Yeah.
Where I'm like, usually I walk into the room and I'm like, hi, I'm Sarah. I'm an occupational therapist. Your doctor referred you to occupational therapy because they thought you might benefit from it. And then I usually go with, I'm curious if you are familiar with occupational therapy. And then that usually sets me up to, and they're like, no. And then usually I have this like, part of what we do is to help make sure that you are safe in your home. Because again, I do so much older adults, like I'm usually focused on safety. But right away with this younger patient, it's like throwing off the script in my head a little bit. So I guess to piggyback on Alan's question, like, how do you usually walk into the room,
right? Like
in set scenario? Yeah.
Yeah.
Yes, yes. And it really depends on what the surgeon said to them as well, because I already know this person has not received OT before or any other rehab services. So depending on what or how the surgeon thinks of OT, then they might be giving them those type of answers like OT is going to work on range of motion, OT might be working on fatigue. But I really want to be able to explain the holistic perspective that OT has the moment they come in and they're asking questions too. But first I want to gauge, what do they know? Maybe they've researched as well. And then based on what they know, I want to be able to do my little OT pitch on what I do in the context of we're outpatient and they're in the community. So I'm not thinking necessarily basic like ADLs, which in this case I also can assume, but I'm also thinking more higher level things. Like they might be struggling going back to work. They might be struggling going grocery shopping, taking care of their children, going out with friends, leisure, participation. So I want to be able to provide some of those examples to them in the context of outpatient. I might also infuse in there in a conversation just to normalize things. I might say something like, a lot of people that have gone through your treatment might be experiencing fatigue, might be experiencing cognitive changes or difficulty with range of motion. So this is quite normal as well. But there's things that we can do about it. So you're able to function, you're able to do the things that you want to do. And so that will provide some normalization as well of these symptoms. And I just don't want to normalize, but also provide solutions too. So I come almost like a two-way approach. Yes, this is normal. And I'm so sorry this happened to you. And a lot of people are going through it as well. But this is what we can do. This is what OT can offer. So tell me more about who you are and what's important to you.
For this particular case, can you walk us through at what point you start thinking about, okay, what assessments am I gearing towards this specific case, or what questions do I need to ask, or what additional information do I need to get?
Mm-hmm. So for her, I already know off the bat, okay, she's experiencing range of motion difficulties. She's experiencing pain. Very likely there's going to be some weakness. I know she's experiencing fatigue. There are some vaginal changes. And so I have 1 hour typically outpatient. So I think it also varies where you're working and where you're seeing this patient. But if I'm outpatient in a clinic, I know that I have about 1 hour to be able to capture the whole picture, most of this picture. So I want to be able to focus on a few assessments that can give me enough information to be able to develop interventions and address these areas of concern. So there's so many assessments out there, and I have listed them in the clinical tool that you're putting out. So based on that 1 hour, what I want to capture is, okay, tell me more about who you are. So the occupational profile. And this is something that we all can do as generalist OTs. We know that we need to get information on who they are, who do they live with, what do they do, what's their occupation, what do they like to do, what's their social environment like. So based on her, I already know she's married. She's married to Mark. And here I'm just coming up with an occupational profile. And she has a 7-year-old daughter. She has a mother-in-law who lives nearby that's able to assist with some home management tasks like cooking and cleaning. Previously fully independent. So before her surgery, she was able to do everything on her own. She was working full-time as a teacher. So I was able to get a lot of information through the occupational profile. But now looking specifically at the areas of occupation affected and those symptoms reported, I'm going to go with a few assessments. So the first one is the COPM because I'm looking for an occupation-based assessment. So I want to know, what are the main occupations affected? What's really important to her, and how satisfied is she with her performance with occupations? So the COPM is going to give me a lot of information within, I would say, 15 to 20 minutes. I know fatigue was reported as well, so I want to do something pretty brief with fatigue just to have an idea of how fatigue is impacting her day-to-day life. And so I implement the brief fatigue inventory, which takes about 3 to 5 minutes, so not a lot of time. Now, there's some assessments out there that will give you a lot more information, like, for example, the FACIT-F. It's one that people use in cancer rehab to look at fatigue, but that would take more time as well. So I'm just going to go with something brief. The next assessment that I want to do is, because she had reported some cognitive changes too. And with women that have gone through this type of treatment that are on this medication, many of them do report cognitive changes, specifically attention, word recall, and impaired short-term memory. So those are some of the 3 common areas that I hear frequently. There might be some that report other things, but those are some of the top 3 issues. So I do want to learn a little bit more about these cognitive changes and how they're impacting daily life too. So there's the FAT COG, and the FAT COG has multiple domains. The first domain, it's pretty simple. It will take about 3 to 5 minutes as well. It's very functional. It lets me know how, again, those cognitive changes are impacting their day-to-day activities. So again, I'm keeping in mind time. I have 1 hour to be able to capture as much data as possible in a quantitative data and qualitative data too, because I'm really hoping to compare some of these numbers to when we finish OT and have that data, the pre and post as well. In terms of the assessments results too, what I'm finding out from her is that she's struggling with showering because of the right arm. She's right-handed as well. So she's having a hard time with her arm being able to wash her back, being able to wash her hair. She is struggling being able to feed her daughter as well. And unfortunately, she has her mother-in-law that's stepping in. But simple things like being able to get her orange juice. Let's say it's the middle of the day and her mother-in-law is not available. She's like, how I can't even reach for a cup in the cupboard. And then I can't even reach into the refrigerator to grab this bottle of orange juice to be able to give my daughter a drink. So she's reporting issues in that area. She's missing her appointments too. And sometimes she's forgetting her medications because of those cognitive changes. And that's really important. She needs to be taking those medications. She needs to be going to follow-up appointments. So now she's realizing, wow, I'm forgetting simple things. And this is all I'm doing. Like, I'm getting a lot of help at home. I'm not working. I'm on medical leave. But yet little things like my morning dose, I'm forgetting my appointment. I almost missed my OT appointment today because of these cognitive changes. So now she's worried about going back to work. She's a teacher. And now she has to start getting things ready to go back to work. There's paperwork that she needs to submit. She needs to go to her PCP appointment as well. So she's forgetting a lot of things. So she's really worried about going back to work.
Yeah, I can see all these things breeding frustration as well, right? Samantha is a deeply independent person, or was, it wants to be again, and I think probably had maybe an unreasonable expectation of that what she underwent as far as her treatment and procedures have been so far were pretty urgent, and like you said, a lot of times people going through these things they don't really have a moment until afterward to be like, wow, I just did a lot, and a lot is very suddenly different for me. And I'm sure that, let's say in Samantha's case, there was an expectation that, like, okay, once I'm through the procedures, I'll be back to normal. Like, my life will return to what it was. And I'm sure that feeling like, okay, there's actually a lot more work to do, and I don't feel like myself, and I have to rely on people in a way that I haven't had to previously. And I'm now worried about, like you said, not being able to go back to my job, which I love. And I feel like I can't be as present in my child's life because I'm tired all the time and my mood is strange and I don't have full range of motion. And how do we build goals around attainable and realistic goals around the what we're looking for, and coupled with this sort of like inbuilt disappointment of where I'm at now?
Yeah, and that's actually a very common scenario too, where during the evaluation, so many things pop up. And at times, this is likely maybe their first time where someone really said, what's going on? What's happening? Tell me more about it. And so what I experienced as a clinician early on was sometimes I was overwhelmed because there were so many things. I'm like, it's not just physical. It's not just the weakness, the range of motion, the fatigue. It's also psychosocial. It's cognitive. There's the chemo brain. There is a mood changes. There is a vaginal dryness. There is the sleep issues. I'm like, there's so many things all over the place. Like, how do I organize this and where do I start? And I think that was a major struggle for me when I was first practicing, because a lot of these individuals were so complex at various levels, and they appeared functional, but they were not. They were really struggling. So one of the things that really helped me to be able to organize and figure out where to start was to use theory. And this could refer to like the model of human occupation, occupational adaptation, whatever that you identify with. It's a framework that helps you organize these bits of information. And so for me, I use regularly MOHO. And this is where a lot of people are like, how do I use theory in practice? I'm going to give you an example of how I use it. So I have a lens. It's almost broken down into 4 compartments in terms of MOHO. So I have the volition, what's motivating the patient, what are their habits and routines, what are their environment like, and we have performance capacity, so all of these skills. And so what are these, which areas are facilitating participation and which areas are not enabling or limiting participation in their daily activities? So with this client in particular, I'm already seeing that in many of these areas are limiting her. Yes, she's motivated. Yes, she has a great support system. So there's some things that are enabling participation, but I'm also looking that her habits are affected. Her routines have been affected. Her roles and all of these performance skills have been impacted. So now once I have an idea of what's going on and I'm organizing all of this information, which is a lot typically, I'm trying to figure out, where do I start? What is the most important thing for the client? And I think the COPM really helps me figure out too, in terms of the list of the 5 occupations mainly affected. So I'll ask the patient, I'll ask the client, where do you want to start? This is all of things that I'm seeing or that you reported during the evaluation. This is within the scope of practice of OT. We can work on this, we can work on that, but what is most pressing for you? And let's start there.
I want to circle back because we have to, we're already behind on our sort of schedule of where we want to be in our discussion. So I'm going to do my best to keep us on task as far as our timing goes. But I do want to circle back to something you mentioned there about, patients potentially like Samantha in this case, appearing functional, but then ultimately really struggling. And it feels like it ties back to something you were saying at the top of our discussion here about this expectation of like, okay, well, you're young and you're strong, and like this like idea of strength, and like I think that's pushed a lot in terms of people who are even describing words like, you say people are like battling cancer, or the terminology we use often revolves around presenting or pushing some kind of like outward strength. Is there a sense of like how to check for this emotional distress, or to dig into this sort of like sixth vital sign of emotional state when you're talking to a patient like Samantha, who maybe in many cases is trying their best to appear as functional as possible because that's sort of like I feel like the zeitgeist of dealing with many chronic diseases, but with cancer as well, is like, I am presenting strength and I'm thinking positively because I know that's part of pursuing my healing process, right? Is there anything you do to try to assess the emotional state of a client or a patient beyond them just walking into a room and telling you everything, you know?
Yes, there's several assessment tools, but I would say even start with screening. If you don't have time, if you're seeing that there's a lot of things going on in your evaluation, you're trying to address a lot of the items in the referral order, and you're like, I just have very limited time. I typically leave it to the end as well, because by then I've already established rapport, given an understanding of what OT is, and to talk about mental health issues. For some people, it's very personal. It might be hard to talk about it. And so for me, what I do, I just leave it towards the end. If I'm just screening, the first question would be, just tell me how cancer has impacted you emotionally. Like, what kind of changes are you experiencing? And if there's family there, a caregiver, sometimes I'll even point to them. I'm like, have you noticed any changes to their mood, like more irritable lately, or they're sadder? And so very frequently, many people will say, yes, like I've been impacted in this way. And so my next follow-up question is like, how are you managing? And this is where I'm also understanding as an OT, do they have tools, like those coping tools to help them get through this time? And some of them will naturally say, yes, you know what, I'm going through a hard time, but I'm able to talk to my husband and he hugs me all the time and I feel support and I feel love, and that's what's helping me get through it. And then you have other people that say, wow, yeah, no one has asked me that before, but it's really hard to see myself in the mirror. Like I look a monster.
Yeah.
And I don't have anyone to talk to. And you're the first time asking this question. I don't even know how I feel. And so right there off the bat, like I already know there's already not just maybe some sort of emotional distress, but even body image, issues going on, which we do see with this population as well.
Yeah. I mean, I know that's, I know just in knowing friends and family who have gone through various treatments and cancer situations, that's like a common theme. It feels like is I don't even have time to feel feelings because there's so much going on with me physically that I like my emotional state becomes this like back burner thing that I'm not even actively thinking about. Actually, to that end, Sarah, I know we were discussing earlier the potential of using a distress thermometer in sessions like these or situations like these. Do you want to elaborate on that for a little bit before we move on to talking about interventions?
Yeah, looping it to like just thinking through this process. I was thinking like with this patient, I would just want to have a distress thermometer. Like if it did come up, like Vanessa said, not something that I would introduce right away, but to have on hand. And then I would connect that to Vanessa wrote a really nice occupational identity goal, and just thinking about the occupational identity disruption that's happened. If there is that emotional distress and it feels related to that shift, like that's definitely a goal that I would write, because it would open up so many treatment options then, like we talked about in our past purpose episode with Alex Slate, that just opens up so many options. So thinking of Samantha, I would probably write one of those goals. I would write a sleep goal. I would write morning routine fatigue goal. I think we talked a little bit about vaginal dryness. I would probably write a goal around there too, just to keep that open. But like Vanessa said, then zero in on what was most important for her at the time. Yeah, I'm curious though, then Vanessa, like with those bank of goals, where you would go from there, especially like closing out that first session, like thinking like maybe if you have an hour, 30 to 40 minutes is that eval, what would be a treatment to end that session with, kind of knowing what we know about Samantha, something that would make her feel like we accomplished something good in OT today.
Mm-hmm. Yes. So I think one of the things that I would want to start with will be, because I know that fatigue has been a major issue for her. She's not able to really do much. She's lying down most of the time. She used to hike and walk, and now she can't do that. So I do want to target fatigue right away. At least give her one or two tools that she can take after our session. So I do want to give her some information about cancer-related fatigue and how, again, this is very normal. Up to 90% of people that have gone through treatment experience cancer-related fatigue, and it can be very debilitating. And so what does the research say? Like, what is helpful to manage fatigue? Well, there's a lot of things that we can do, but let's focus maybe on one or two that we can do maybe the next week or before our next session. So we know that movement is extremely beneficial, physically, emotionally, cognitively. So I know she used to walk, let's say, 10 blocks every single day. So what is feasible? What is realistic for her in the next week, maybe before our next session? Maybe it's just half a block. Maybe she's able to just walk for 2 or 3 minutes and come back. And so there's people that we got to sometimes challenge the mentality of, either I do it exactly the same way before or I don't do it at all. So this is where our CBT or sometimes thought reframing interventions are really helpful too, where I'm like, there's a lot of middle ground too. Maybe right now, for now, we can't do the 10 blocks, but perhaps we can do 1 block. And let's see how that feels. So for a lot of people, once they do it, they feel accomplished. They feel like, hey, you know what? It was actually really helpful to go outdoors, get some sunlight, maybe walk my dog or be with my husband for just 1 block. It was very brief, but maybe that was the highlight of my day. I was able to go out, get some fresh air, get some sunlight, and get some physical activity. So that will be one of the first ones. I'm also thinking of the physician order as well. So they're looking at range of motion, looking at fatigue, vaginal dryness. So we do want to address that range of motion and the strength that that's very debilitating for her. So we can start some sort of a range of motion exercise program as well. So this could be very much functional, or it could be exercises. She might already be doing some. So I want to see, what does she have in her toolbox? So maybe starting with some shoulder flexions, some shoulder abduction, some reaching in her natural environment. So how can we get more movement? Because frequently what I see is that if there's pain, there's a lot of guarding of that arm. People are like, I don't want to use it because if I try to reach for the cup, it's going to cause a lot of pain. So I'm going to keep it right here to my side. I'm going to compensate with my left hand. And so that's going to lead to even more tightness and more pain. So we also have to address those fears, that psychosocial component of those limitations too. So not just the physical, but like letting them know that that's part of the process, but only as tolerated. So let's see what we can do now and then slowly progress in terms of range of motion. But we want to get started with at least some few exercises. So thinking of her, okay, we have 2 interventions right there. We have the range of motion exercise program. We have interventions related to fatigue management. And I also want to do a little bit on some cognitive strategies and maybe some caregiver education. Just very brief, just touch on a few things. I know she's forgetting a lot of appointments, but I know that she told me that she used to use a planner all the time as a school teacher, but she hasn't been using one. So let's tap into those cognitive strategies that have worked for her in the past. I don't want to necessarily introduce new ones. Let's see what she already has in her tool set that has previously worked. So I'm like, let's bring in, maybe go to Marshall's, go buy yourself a new planner for 2025, and let's start using a planner again to be able to write down those medical appointments or those reminders for your medication. And the last thing is caregiver education and training as well. We know her husband is there with her. So maybe some brief information on, what he's going through and then ways that he can better support her. And that may be things like reminding her or sending reminders for her, encouraging her to do the exercise program or doing it with her, or setting time to do those 1-block walks every single day with her.
Mm-hmm. Yeah, I was gonna bring up actually, Liz. So let's assume, that our spouse Mark is in the room for the last 15 minutes, and we have this opportunity to kind of talk patient and family education with him. And as part of that discussion, our patient Samantha says, "Oh, I think I would really like for Mark to be present for the entirety of our second session to discuss intimacy strategies." What would be your next steps towards looking at a session 2 with both the patient and the partner present?
Yeah, so with the first session, again, I want to focus on that education because a lot of them are still in the dark as well. If the patient's in the dark, very likely the caregiver's in the dark as well, or the partner's in the dark. So I do want to educate them on, what they might be experiencing, validating those concerns, those impairments or limitations, and then making those suggestions like I made earlier in terms of how they can better support them. If the patient wants to work on sexuality for the next session, we can definitely prioritize that. And I can give them an idea of what to anticipate. So I also want to know what's going on in terms of intimacy. I know right off the bat there's vaginal dryness, but is there anything else going on? So aside from the physical issues, could there be emotional issues? Again, she's lost that breast. How is she going to feel now being with her partner, with her new body? What is she thinking? What is she feeling too? So in the next session, I do want to explore a little bit more if there's any other physical issues and the emotional issues impacting intimacy. And again, fatigue is another one that can also impact intimacy, for individuals who are dealing with especially moderate and severe fatigue like her. Maybe by the end of the day, which is when she was used to being intimate with her partner, she's just tired. She's wiped out, So how can we encourage intimacy, maybe in different forms that can help her feel connected with her partner again? And we know that social support is so, so beneficial, so important during the recovery process.
Yeah, I'm sure. And there might even be a fear component in there as well, right? Like the idea of, I suddenly feel more fragile than I've ever felt. I suddenly feel, find myself, like you said, very protective of parts of my body that are in pain or discomforted. And it's almost impossible to think about anything else when something's actively bothering you in a sense. So,
Yes.
and how involved, sorry, go ahead, please.
Oh, I'm also thinking the partner as well. So you mentioned some really great points in terms of how the patient might be feeling, the body image, the range of motion limitations. She might not be able to hold herself up if she's in a certain position, the pain, the anxiety around vaginal pain as well with sex. But I'm also thinking of the partner and how they're feeling too, because a lot of partners are afraid. They're like, can I even touch my loved one? Will that trigger more pain? What can I do? Or what's allowed versus not allowed? So they also have a lot of anxiety, a lot of fears, and they want to be intimate. A lot of patients, they want to feel supported and loved by their partner. So they have a lot of questions. So I do appreciate when the partner comes into the session as well. But that's a question that I typically ask at the beginning too. Like, do you want to do the next session when we're addressing something very personal like mental health or sexuality? Do you want to be alone, or when do you want your partner to step into the picture?
I do want to, I promised we would save some time for questions, and I would like to do that now. Sarah, do you have anything you'd like to say about our scenario with Samantha Tan before we move on to some Q&A from the audience and some of our pre-submitted questions?
I just had one more logistical question. about, I always think the most important question is, or the most important moments with the patient are one, when you enter and how those like first moments of the encounter go. And then second, how you leave the room and how they feel as you're walking out. And so I was curious to hear from Vanessa, just like what she logistically says as she's walking out the room. I was thinking today, I was like, I think for myself, usually it's something like, thank you so much for sharing your story with me today. And maybe ending with, did this session feel helpful? And is there anything you want me to be thinking about for the next time? Just so I get like that concrete, like, was this helpful today? And what can we do differently next time? But Vanessa, what do you do?
Yes. I think for those last few moments, I'm trying to think, I'm trying to put together the entire evaluation in my head as well, and what we've
Yeah.
been doing, what we prioritize, and keeping that in mind as I develop the treatment plan and the future interventions too, and where they want to go as well. Sometimes they don't know what they don't know. So there's times where I have to mention, okay, I think that would be a great long-term goal, but realistically, maybe in the next few sessions, we can work on this. So it might be just partially that, but we could aim for that in the future as well. Because they might say something like, I want to be able to hike 10 miles again, by next month. And so I have to be able to figure out what is realistic, what is achievable, so they can have that boost of confidence as they're meeting those goals as well. One of the things that I really like to focus on towards the end of the session is to provide hope, is to really give them a picture, help them create a picture of what their life can look like in the next few months or next few years. I think for a lot of people, they just have no idea. They're like, I don't know how to move on. Like, I might be stuck. There might be like a functional freeze, especially if there's that big emotional traumatic component. And they have gone through trauma. It's a medical trauma. So I like to paint a picture of what is possible. Like, they can return to work. They can do these things again. It's going to be a recovery process. We don't know how long it's going to take, but there's support. And that's why I'm here as an OT, is to support them in meeting those goals, to get them back, to be able to craft the life that they want. Because I don't think realistically will ever be the same, right? Just like anybody who's gone through trauma or through an injury or an accident, we can't expect that person to be the old person. They're going to be different, but what does that look like for them, right? And I want to be able to help them reach those goals. And so one of the keywords that I use is, we're here to help you rebuild your life. I really don't like to use, like the new normal, or try to get your life back or to where you were, because I think it's even possible to be even in a better place, right? Maybe before you weren't really taking care of your health. Maybe before you really didn't care about medical appointments. So I think it's very much possible to be able to move on and to get to a place that you're happy and satisfied, good quality of life, and maybe even a better lifestyle now that you're so aware and so mindful of your health. So I do want to be able to provide that vision for them moving forward, that life can move on and it could be really, really great. And there's a lot of support. And that's why I'm here as an OT. So tell me more about who you are and where you want to go.
It feels like what you're saying transitions actually really well into a question we got in the chat from Allison Johnston. The question is, working in a hospital setting, I've worked with younger patients who have terminal cancer or their cancer has returned. I want to encourage them, but also not instill false hope and show I'm understanding them. Do you have any recommendations?
Mm-hmm. There's actually a term now that I've been hearing frequently, which is toxic positivity as well.
Mm-hmm.
And I do hear that a lot. Sometimes family members are very much using that as well when they think they're being supportive as well. And they're saying, don't, forget about that. You're going to move forward. Just be happy. You're alive. So one of the things that I encourage is to really validate that person's experiences. And I like to use those therapeutic modes. So I don't know if you recall back in OT school learning therapeutic modes in practice. And one of them is empathetic therapeutic mode. So just sitting there and just learning from their experiences. So what are they going through? So tell me more about how you're feeling. What does this mean? What are your fears? What do you want to do next? So I think it's not everyone can do that for them. And I think that's what makes OT really unique, is that we are able to sit and provide that space for them where they're able to share how cancer has impacted their life. And metastatic disease is a very difficult one too, because now you're coming up with the idea of, I'm going to be living with cancer. And there's a lot of stigma around cancer. But now we're seeing again with so many technological advances that people are able to live long and live really well after cancer. But I think this is why so many supportive services are very important, from OT and PT and social work and psychology, is to be able to provide the support they need to help them move forward in life.
I'm going to ask you, we are down to like our last 3 minutes here, but I'm going to kind of double whammy you with a pair of questions here to take us out on. For pretty much this entire discussion, we've been focusing in on this specific case that revolves around an adult with cancer and dealing with, all kinds of issues that are specific to adulthood. What feels to you, first question, what feels to you like the biggest difference between cancer rehab for adolescents versus older or established adults? And then secondly, what's the most important takeaway from the conversation we've had today that you would want to end us on?
Mm-hmm. So to answer your first question, goals are typically different. Life stages are definitely different. When I'm working with an older adult, they might be in a position where they can retire. They don't have to work. They might not have to work anymore. Maybe financially they're set. They have a home. They have adult children that can support them as well. They can move in with their grandchildren as well. So there's a different life stage and different resources and different support system. Whereas maybe a 38-year-old might be responsible for taking care not only of their children, but maybe even their parents. And now they're having to deal with cancer. And maybe they're not in the position to be able to retire. They're maybe just starting their second career as a teacher. And so they have to be able to go back to work and provide for their family. She has a 7-year-old. Maybe she has student loans. She maybe just got a mortgage 2 years before her diagnosis. And she's the only daughter. So when I'm seeing an AYA, I'm thinking about those life stages and how it does look very differently from an older adult, which again, we have to consider, especially even when thinking of pediatrics as well. We're thinking of what's their age and developmentally where they're going through, and they very likely have their parents for support as well. So similarly, we got to have that same approach with the AYAs, that they are in a very unique position. And also what we're seeing too, molecularly, and some cancers are very much uniquely seen in the AYA. So it's not just developmental stages, but also molecularly, we're seeing that AYAs can be very different from older adults and pediatric population.
Gotcha. And then, if just in, let's say, 3 sentences, if you could give us what you think the most important takeaway from our conversation today has been.
Knowing that AYAs are very unique and they're going through just a complex developmental stage in their life, they still need support. They need support. And I feel like OT, we have the skill set. When we think of AYA survivorship, their main goal is going back to life. And so when I think of experts and being able to go back to normalcy, to go back to daily functioning, I really do think that we are the perfect discipline, the ideal discipline to look not just at the physical issues, but the emotional and the cognitive, to be able to help people get their life back or to be able to rebuild their life. And in rebuilding their life, we are building not just activities, not just routines, but it's their identity. It's how they feel about themselves, what they feel about life. And so I really wish we could really get there. We can not just get in to see them, but I wish that we could get in early as well, because we know that the earlier we can get in, the better the outcomes typically.
Vanessa Yanez, thank you so much for joining us for this OT potential discussion on cancer rehab for young adults.
My pleasure. Thank you for having me.
Of course. And thank you, Sarah.
Thank you, Alan. Vanessa, it was just awesome to learn from you again.
Yeah, I feel like we learned so much, and I'm looking forward to our next discussion. Thank you all for being here.
Thank you.
Thank
Bye.
you.
Thank you for joining us on the OT Potential Podcast. To earn 1 hour of AOTA-approved continuing education for your time today, you will need to sign in or sign up at otpotential.com. Once you're in the OT Potential Club, you will find a 5-question post-course quiz connected to this episode. When you pass the quiz with a score of 75% or higher, you will be able to download a PDF certificate that certifies your completion of this course. Okay, I want to thank you for joining us today, and we'll see you next time.